The chairpersons for the final session today are Dr. Yash Lokanwala, Adjunct Professor of Biomedical Engineering at IIT Mumbai, Dr. Nityanand Chowta, Professor at KMC Mangalore, and Dr. K.S. Bhatt, Professor of Medicine, Father Muller Medical College, Mangalore. I invite them to take their seats. I invite the speaker, Dr. V.S. Prakash, onto the dais to speak on the topic post-myocardial infarction, patient with recurrent wide QRS tachycardia. I request the chairpersons to introduce the speaker.
Good afternoon. Wrong part of the day to step in, and that too after all this sci-fi and Star Trek. Wrong person. Never follow this gizmo guy. It's always a problem. Obviously, let's come back to terra firma, hit the Mother Earth, and try and see what basics we need to know about. It's going to be a summary of most of the talks that you heard yesterday and today, all the basic stuff. So here goes. Broad QRS tachycardia post myocardial infarction. This I'll just do case illustrations and I won't bore you. I know lunch is waiting. 55-year-old hypertensive male admitted with acute onset of chest pain, ECG, showed acute extensive antral MI on admission. And this was his angiogram. He had a middle AD total occlusion, underwent primary PCI. An hour later in the CCU, this is what was noticed. So what do you think is the problem? That was his ECG before, post-procedure, pre-procedure, and then in the CCU, this was his ECG. So what are we dealing with? Sinus tachycardia? How many would say this is sinus tachycardia? I know you're all hungry. SVT with aberrancy, idioventricular rhythm, accelerated idioventricular rhythm, at least there's one person. Ventricular tachycardia, none of the above, don't know. So we are dealing with wide QRS tachycardias. Wide QRS tachycardia rate more than 100 per minute, QRS duration more than 120 milliseconds. So it could be atrial with aberrancy or it could be ventricular tachycardia, supraventricular versus ventricular. So how do we go about a systematic approach to discern wide QRS tachycardia and try and put in the diagnosis? Review the clinical data, recognize at first glance, find the P waves, match the P and the QRS, pinpoint the diagnosis, confirm. That's the steps. Review the clinical data. This patient had an acute MI. Patients with heart disease and wide QRS tachycardia, 95% of them will have ventricular tachycardia unless otherwise proved. Structural heart disease, wide QRS tachycardia, it's VT unless otherwise proved. Then recognize at first glance. Some of these arrhythmias are very easy, spotters. You just look at them and you recognize. So let's see the next case. 63-year-old male admitted with acute coronary syndrome, serum creatinine of 1.6 milligram per deciliter. Echo revealed mildly impaired LV systolic function with wall motion abnormalities. Coronary angiogram revealed a bad double vessel disease, but however, he underwent PCI with reasonable results. Pre-discharge day, midnight. That midnight, he was in the ward. So, spotter. What is this? What is this? Either you're hungry or you're sleepy or you're not attentive. VT. Yes, white curious tachycardia. Recognize at first glance. You can't miss this, no? So similarly, you can't miss that. Ventricular fibrillation. Results from multiple reentrant wavelets in the ventricle, usually occurs with structural heart disease, rate more than 300, rapidly lethal if not defibrillated. The first 20 seconds, that's all it is. If you don't defibrillate in the first 20 seconds, whatever may be the rhythm, it might still continue to be VFib, but they will not come back to life. The first 20 seconds is vital. Unless he gets an L1, right? Incidence of primary VF in MI is about 5% in whom a documented rhythm is obtained. It occurs without antecedent warning in about half, because only less than 50% reach the hospital. So all of them would have had a primary VF. So it's more than one half of these patients would have had a sudden death because of VFib. And factors associated with increased incidence of VFib is current smoking, left bundle branch block, and hypokalemia. A question for you. VF has a worse prognosis in inferior wall MI versus anterior wall MI. How many will say true? MI inferior wall versus anterior wall. VFib is worse in inferior wall MI versus anterior wall MI. How many would say yes? How many would say no? Excellent. You people are still alive. Thanks. Patients with anterior wall MI and VFib have a worse long-term prognosis than those with inferior wall MI. And VFib may occur with reperfusion even after thrombolytic or catheter-based reperfusion therapy. Treatment is obviously prompt defibrillation. We discussed about defibrillation and cardioversion, so on and so forth. And beta blockers also are known to decrease the incidence of lethal ventricular arrhythmias, including VFib, in the peri-infarct period. Another spotter. What is this? Recognize at first glance. Excellent. R or T. So this is what would happen to him, an R or T. A 65-year-old female diabetic hypertensive admitted with acute heart failure, elevated cardiac biomarkers, marginally elevated creatinine, echo EF was about 35%, elective CAG after stabilization of heart failure. She had a, I'm sorry, this angio is not playing, I think. She had a bifurcation lesion, underwent bifurcation stenting with reasonably good results. Second post-op, post-PCI day, she developed this arrhythmia. What do you think this is? Not a very good ECG, but still I think you can carefully. It's a white curious tachycardia. You agree with me? Right bundle branch block morphology. QR in V1, and if you carefully see, there's something in the rhythm strip that you can't miss out, at least in the first half of the rhythm strip. There's a little bit of deviation of the baseline. What are you seeing there? You're seeing something in between, which is not there all the time. Look at that. What's that? AV dissociation. Excellent. There's an AV dissociation there. Very clearly, this lady is having VT. So she was given IV amiodarone infusion, 1,200 milligram over 3 days, and she was also on triple antiplatelets. We generally follow triple antiplatelets: aspirin, clopidogrel, and cilostazol. And then she was shifted to the step down because she was stable. 4th day. This is what happened to her. It was noticed on the monitor. So what do you think is happening? With a TDP while in the step-down ICU. So it was obviously a TDP, cardioverted, thought probably it's due to a occluded stent. Check angio revealed patent stented segments with TIMI-3 flows. And then baseline, when you analyze the ECG, there's a clear-cut QT prolongation. And then we realized amiodarone can cause QT prolongation, but less of proarrhythmias unless you add on some other drug. And unluckily, we had added on cilostazol. Cilostazol is also known to prolong the QT. And on top of amiodarone, this is what created the problem. So she had a TDP. So then we move on to find the P wave and match the P with the QRS. This is what you saw in that AV dissociation. The same thing is trying to be, I'm just trying to show the same thing here. So it's very, very important to clearly make out AV dissociation in trying to differentiate supraventricular from ventricular tachycardia. It is a solid sign. But AV dissociation is virtually diagnostic of VT, but only apparent in 1/3 of VT. So in 2/3 of VT, you still find 1:1 AV association. The next important thing you need to look for is capture and fusion beats. Capture is where a dissociated P wave causes total or partial activation of the ventricle in advance of the next beat. So that's what you see here, clear-cut presence of dissociated P, fusion complexes, and goes in favor of a clear-cut white QRS tachycardia favoring ventricular tachycardia. Now coming to our patient that we showed in the first. If you see carefully his ECG, very clearly there have been P waves intermittently and not associating with the QRS. So telling us very clearly that that patient, the first patient, had sustained monomorphic ventricular tachycardia while shifted in the ICU. So the morphology criteria for VT, all this has been discussed at length, Brugada criteria and all that. So I'll skip this. And another important thing is when you see a QR complex, it indicates CAR, and that goes in favor of VT, and they are present in approximately 40% of VTs after myocardial infarction. The presence of a Q and an R, which I pointed out in the first ECG. So QR complexes suggest VT. So to summarize, consider that all white QRS tachycardias are VT unless otherwise proved. Even by chance, you are not able to decipher whether it's VT or supraventricular. Treat it as if it's VT. It's important because VT is more sinister compared to SVT with aberrancy. You are not harming the patient by treating him as VT. In unselected patients with white QRS tachycardia, 80% are VT. In patients with heart disease, 95% are VT. VT can be associated with normal blood pressure, and ECG criteria to distinguish VT from SVT are not 100% specific or sensitive. You have a diagnostic algorithm. I'll jump this. Now the last ECG probably. 50-year-old male with acute onset of retrosternal pain. What's the diagnosis? What's the diagnosis? White QRS tachycardia. Mind you, he has chest pain. There's clear-cut ST segment elevation in the inferior leads. And what is happening? What else is happening? We know there is an acute coronary syndrome. We know there's an inferior wall MI accepted. But what is this white QRS so-called What's happening? This was his angiogram. He had a nearly occluded right coronary. Irregularly irregular, isn't it? So there's an atrial fibrillation going on there. So that was atrial fibrillation. Premature atrial contractions can be seen in one half of patients with MI, and it could be due to atrial or sinus node ischemia, atrial fibrillation, pericarditis, anxiety, or pain. So obviously, the attempt should be made to restore sinus rhythm, if not rate control at least, to aggressively minimize the oxygen demand. You can still use amiodarone. Then we move on to another question for you. Early VT is of more sinister nature versus late onset VT in the course of myocardial infarction. True or false? Is early VT more sinister or not? Early VT is more sinister or late VT is more sinister? Early VT is more sinister. MI, is early VT more sinister or late VT? Late VT, isn't it? Primary ventricular fibrillation, if the patient is monitored, can be easily taken care of. But something occurring much later is obviously of sinister. VT occurs in 10 to 40% of cases of MI. Early VT is usually transient and benign. Late occurring VT is associated with transmural infarction, LV dysfunction, hemodynamic deterioration, has a markedly higher mortality both in hospital and long term. The mechanism is usually divided in the first 30 minutes and 3 to 6 hours or as long as 3 days. Early phase is divided into 1A, that is the first 2 to 10 minutes, and the next 10 to 30 minutes. And usually the first 10 minutes is usually due to re-entry. The second, third 20 minutes, mechanism is not very clear, but most probably due to abnormal automaticity. And arrhythmias in the late phase is due to surviving Purkinje fiber. See, the Purkinje fiber is bathed in blood. So even though there's an infarction, Purkinje fibers are still alive. They are bathed in blood. So they are still alive and they form the reason for arrhythmias generation in somebody who develops arrhythmias much later in the second portion of the period. So located within the subendocardium, which displays abnormal automaticity, and this shows increased sensitivity to catecholamines. Arrhythmia occurring in the chronic phase after 3 days is invariably re-entry. I'll skip this. Okay, now does this rhythm bother you? What would you do? An acute MI, understandable, patient is having frequent ventricular extrasystoles. So would you be bothered? What would you do? Treat or not treat? Worry, not worry? Not to worry? To worry? Yes, that's what. Those are the sinister ones that you need to look at. Generally, VPCs, conservative treatment, you don't have to worry about. No routine antiarrhythmic drugs for these. Determine whether recurrent ischemia, electrolyte, or metabolic disturbances. And if the frequency is more than 5 per minute, multiform configuration, early coupling like R-on-T, repetitive patterns in form of couplets or salvos, these are supposed to be the malignant kind of ventricular premature beats which need to be addressed. And in many of these patients, you can take care of these arrhythmias by early administration of IV beta blockers. And so VPCs more than 10 per hour are an independent risk factor for subsequent mortality, both total and also for sudden cardiac death. I'll skip this. And finally, about implantable defibrillator cardioverter, it's recommended when post-MI, after 40 days, if the patient has LV dysfunction less than 35%, it becomes a primary indication for ICD implantation. And in the presence of acute MI, 48 hours after the STEMI, before discharge, the patient has been diagnosed to have sustained ventricular tachycardia or fibrillation, and the arrhythmias are not due to transient or reversible ischemia or reinfarction or metabolic abnormalities, then that becomes a class 1 level of evidence B for implanting a ICD very early post-MI. But many of them generally die of pump failure rather than due to arrhythmias. So that's what has been found in these two studies. It's found that the ICD reduced sudden cardiac death in the early phases of MI, but increases the overall mortality due to other cardiovascular causes, heart failure deaths. So finally, VT management, you have LV dysfunction, ejection fraction less than 35%. You can take up for an EP study and ablate the focus, or automatically you go in anyway for an ICD implantation. So we have whatever health plan you want to take, you have a choice here, the basic, the advanced, or the VIP. And similarly so, this lady is waiting for her husband to come back home. Late, you get a rolling pin. Drunk, a bigger rolling pin. Lipstick, that's the end of you. So finally, the message for white curious tachycardia in the presence of myocardial infarction, act like ducks. On the water surface, look calm and relaxed. Don't panic like my intern did. But under the water surface, pedal like mad. Thank you.
Thank you very much, sir, for your lucid presentation.
I know, that's a little too much, sir. We normally give just 5 milligram. That's it. Exactly, exactly. And with the primary interventions now, even the requirement for beta blockers has come down, but definitely it has its role to play.
We don't give 3 active.
No, definitely not.
So those who are on amiodarone loading dose, we are worried about a long QT interval.
Yes.
Do we can add on a beta blocker in that so that it must
Definitely, that would definitely help, especially in the setting of MI. But see, primarily, I'm sure many of